All right. All right. We are live. Just gonna give it a couple seconds to let people come in. Let me pin this post. What's going on, Yura? Going on, Carito? Comments. What's going on, everyone? Give me a thumbs up or a wave or anything if you guys can hear me. Just want to make sure the audio is working. We're testing out some new audio. What's going on, Sandy? What's going on, everyone? Jess, hello. Maddie, awesome. So today I'm just going to be hopping on for 20, 30 minutes. We'll keep it real short. Just going to do a little Q&A. You guys can go ahead and ask whatever you want. First couple minutes, I'm just going to talk about some of the posts from last week. I had posted on a title was regrowing knee cartilage was for an oats. Just wanted to make a little correction. I caught this a little bit after I posted it. It was too late to delete the post. But long story short, with an oats procedure where you take a bone plug from another joint in the body or a cadaver and you put it in a weight-bearing joint, you're not necessarily regrowing knee cartilage. What you're basically doing is just trying to, quote unquote, repair or replace knee cartilage that you may have lost, moving it from one area of the body or from a donor tissue into another. So just wanted to set the record straight on that one. Also, another thing, we posted a couple posts with patients, actual patients of ours or patients of others this week. I just want to say, don't ever comment negatively on any post for a patient. That's where we're going to draw the line. If it's a picture or video of us and I'm exercising and my form looks like shit, call me out. Let me know because I am making that content for you guys and I'm trying to make it look good. I'm trying to make it look quote unquote perfect. I'm trying to do things correctly and being in teaching moments. So 100% call us out if our form does not look good. But when it's a patient going through real rehab, who's really hurt, who's actually in the clinic going through their training and their rehab, please don't comment on the form. You don't know anything about that person's rehab. You don't know anything about what that person's going through. You saw a 5-second snapshot into their entire rehab journey of 2 reps. So we're just gonna leave it as that. Don't comment on any patients because that's not absolutely uncalled for. Anyways, all right. So a lot of you guys are starting to join in. If you guys have live questions, let me know. I'm going to answer them. We're going to try to do these. I think as you've seen, Arash and Craig and I, we're going to try to do these a little bit more often, just to keep being able to answer all your guys' questions. We get a ton of DMs and a ton of emails, and it's just really hard to keep up with all of them. We figured that it's going to be a lot easier for us to answer these questions here live with you guys. What's going on, Craig? It's going to be easier to answer these questions live with you guys. So let's go back. I'm going to go back a little bit from Andrea. Is it okay to foam roll the calf for the Achilles tendonitis or keep tight to strengthen it? It says in your post, don't stretch, keep stiff. So if you do have Achilles tendonitis and it's true tendonitis, meaning it's an inflammatory condition, there's probably going to be some time we're going to want to relatively rest for a little bit, decrease the loads. Going back to that other post, that injured athletes don't rest. When I posted this thing called POLICE. So we know that when you get hurt, there's this acronym called RICE. It stands for rest, ice, compression, elevation. It's really cool. I read in this article, there's a new one that is POLICE. So the ICE at the bottom stays the same, the ice, compression, elevation. This is for acute injuries too. But the top 3 is where it's really cool because that first one, rest, needs to be rechanged. The P stands for protection. So when you have an acute injury, you do want to protect it, meaning you do want to decrease the loads to it. You do want to protect the surgical graft, the injury, whatever it might be. But then the next 2, the OL, optimal loading, you need to find an optimal amount of loading that's safe and below the threshold of what would be considered dangerous. But you need to have some sort of load in there to stimulate the tissue, whatever tissue it is, to heal. So definitely try to do some strengthening, but again, you want to find an optimal load for you. Best to consult with a PT in person to find out what that load might be for you. For Bonser, any jumping injuries, rehab, a ton of ways that you can go through your progressions of jumping. We are going to create a program and an article on that to help guide you guys through some plyometric progressions. But essentially, to make it super simple, start with jumping first, which is 2 feet to 2 feet, then go to bounds, which is from my left foot to my right foot to my left foot to my right foot, and then go to hops. And then you can play with different vectors by going front and back, which is called the sagittal plane. You can go side to side, which is the frontal plane, and then transverse, which is basically going like in a rotation, counterclockwise, clockwise. Those are very simple way to put it, but start with that, and you can always make progressions from there. From from Spain, we enjoy it. Thank you for your support. We really appreciate it. Dr. Nemo, what kind of hair product do you use? This is actually really funny. So I was in China. I did a clinical rotation in China 2 years ago. Yeah, wow, 2 years ago. There was this Japanese product that I used there that I loved. It's really, really hard to find it. It's on Amazon now. I forget what it's called, but I ran out of it. So then I had to go to CVS and I bought Axe. Has hair products now. It's so crazy. I remember being in middle school, the men's locker room, all we did was spray Axe, and now Axe has hair products. That's what I'm using now. It actually has some smell to it, so it's actually kind of funny. What's going on, Craig? Adam, is it possible to treat and fix hallux valgus? From a PT perspective, there's not anything I'm going to do to change your anatomy. You may need to have surgery for that. Best to consult with an orthopedic surgeon. There are things like footwear changes that you can do to maybe decrease some of the stresses that you're putting on certain structures that may be causing your discomfort. But know that it's a very common issue with all the closed-toe shoes that we wear now. What's going on, Eduardo? What's going on, Al? Curtis, hamstring injury behind the knee, rehab. It keeps happening every football season. Sounds like you may need some eccentric hamstring strengthening. So we posted a lot on the Nordic hamstring curls. I would start there, implement that into your football season, into your preseason and your postseason. We actually posted a cool article on, where is it? I'm trying to think where it is. Search our website for Nordic hamstring curl and you'll find it there. Adam, hammer toes. I don't see many of those. Not gonna be able to talk about that. Zuma, what's up? Amid, what's up? Fatu, what's up? Nathan, best way to fix correct knee valgus when jumping. So that's only if you determine that knee valgus is an issue with jumping. There is going to be some sort of knee valgus, and in that jumping post, you are going to have some sort of dynamic knee valgus as you load and you come up. What is excessive, what is not, that's going to all depend on the person that you have in front of you. But you can look, starting at the foot, like what's the pronation look like? Are they over-pronating? Do they not have control in the pronation? Then you can go at the knee. Do they have quad strength to actually be able to hold that load and be able to bend their knee? Then you can go up to the hip. Do they have that external rotation, adduction, abduction strength to be able to control it? A lot of different ways to do it. That's from a strength perspective. There's motor control things. I would go see a PT in person to see if that's something that actually is an issue that needs to be corrected, and if so, how to best tackle it. NT lifts, what's going on? My shoulder gets a sharp pain around the rear delts at the top of my shoulder at the joint area. Is it a tendon? Hard to say without seeing you in person, but it could be a tendon. It could be just a little bit of joint restrictions at the joint itself. I would say strengthen up your shoulders, get your rotator cuff brutally strong and your periscapular muscles brutally strong. Do that for a month, see how the discomfort, see if it's gone away. If it's gone away, great. I expect it to. If it hasn't, go see a PT in person. Sandy, best exercises for rectus abdominis strain. We have a ton of exercises on our exercise library. If you go to www.theprehabguys.com/video library, you will see a ton of exercises for the quote-unquote core. I think we even have it labeled by muscle groups. We are completely relaunching this exercise library in mid-April. It is going to be epic. We know that there's a ton of flaws with it right now. The UI is not as clean as it could be. It will be on par with MedBridge, HTTP Go, all these other platforms in terms of how the user interface will be. The biggest part about it, as you guys have seen, we've been leaking some of the videos on social media, is the tutorials. We have 1 to 2 minute long video tutorials for patients where we walk you through the exercises, showing you all the different cues, things to look out for, compensations. And that's really where it's going to set it apart in comparison to other programs. What's up, Dr. Chudari? Andrea, thank you. Nadisi, is there some sort of progression to start running again after a healed injury? Yes, so we have a return to running progression article. Go ahead and Google the Prehab Guys return to running. That protocol is specific to lower extremity injuries, but the basis to returning to any injury is basically it's called graded exposure. So say you haven't run because you had a healed, healing a herniated disc. So for example, I had a patient yesterday seeing for that. He hurt it about 5 weeks ago. Numbness and tingling is all gone. There's a little bit of discomfort in his back. I started him on the elliptical. We did the elliptical yesterday for 15 minutes. I asked him how it went. He said it felt great. Now we're going to monitor that response to see how it feels today, which is about 12, 24 hours later. As long as that feels good, okay, I know the elliptical is great. I may run with the elliptical one more time. I may increase the volume to say 20, 25, 30 minutes. If that's good again, then I'll try running and I'll have him run for 5 minutes, maybe even run for 10 minutes, maybe even do intervals. So that means running for 2 minutes, walking for a minute. Basically, just don't go from 0 to 100 real quick. Make sure there's some steps in between and you should be okay. Melissa, I'm 10 weeks post-op from ACL. When do you think weightlifting should be appropriate, even hot yoga? If you have a surgery, best to consult with your orthopedic surgeon and PT. Don't let any advice that I have overstep anything. You need to go consult with the people that know your knee the best. Know that weightlifting is appropriate whenever they say it is, and weightlifting could be something as simple as quad sets. That's weightlifting as well, and hopefully that's something you've been doing since day one. What's going on, Elite? Dom, Bob, what's going on, everyone? Curtis, should I try resistance bands to get the hamstring stronger at no weights? If you're pretty healthy, I think you should be fine going straight to weights. Bodran, no worries. Fiona, best exercises for psoas. Same thing. Go to our exercise library, type in hip flexors under the muscle group, and you're going to find a ton. The psoas march is one of my favorites. It gets the lower abdominals as well as the psoas. Going on, guys. Sweden, what's up? You're in the house. I don't know if you guys saw the post I put on the story today. These are some cool cups. Craig's aunt made them for us. These are really sick. But I posted on hot coffee versus cold coffee, cold brew. I've been a big fan of cold brew lately, so I've been drinking a ton of that. Any suggestions for kneecap pain? Yeah, you can move your patella, move that sucker as much as you can, and get your quads just brutally strong. NT list, knees feel like they're weak and feel sore after squat or sit for a long time. Any tips? Get your knees stronger, work them out, work your quads, work your hamstrings. If sitting's uncomfortable for a long time, get up and move every hour. Set a timer to get up and move. I tell patients that have issues with sitting to put their water on a different desk so they are forced to get up whenever they're thirsty instead of having it available to them. So just try and move. Movement is medicine. Maddie, there's a bit of a trend towards shoulder instability with my high school athletes. They lift 4 times a week with coaches. Advice on what I should tell them to incorporate for injury prevention. That's tough without knowing exactly what they're doing in their lifting programs. I mean, I think you should start there, figure out what type of stuff they're doing in their programming, see where there may be some holes or some things that you can better incorporate. It only takes 5-10 minutes. You can give them some stuff that they can do as their warm-up. Say if lifting with their high school team starts at 1 p.m., be like, all right, well, I want you to get to your facility at 10 minutes before that, 12:50, and you're going to do just these 2 exercises to fatigue or something like that. But I mean, you're going to have to work hand in hand with the S&C coaches and figure out what you guys can do as a team to help work on the shoulder instability that you've been seeing. Recommended treatments for hip pinching. I would go to our YouTube, look at Arash's last Instagram Live Q&A. He talked a lot about hip pinching and things to do. I want to say Arash also wrote an article on that. So thanks, Craig. Jared, I have some boxers having trouble with AC joint and biceps tendon. Can you recommend anything to help prevention? That's tough. You need to figure out why they're having those issues first before recommending anything to prevention. So I would try to figure out why they're having some of those issues in their AC joint and biceps, see what things you can strengthen, see if there's anything mobility restrictions, see how sensitive those joints are. It's really hard to give recommendations like that without seeing the people in person. So Adam, what are your thoughts on knee braces long term? I don't know for any other things besides ACLs. I do know that if patients feel more confident with them, I'm going to be totally okay with them using them. Research shows you don't necessarily need them. However, if the patient feels better with them, then they do provide benefit. So again, it's all about patient-centered care. If the patient is super fearful and they want a brace, don't not give them the brace. You can eventually try to wean them from it, but you should definitely give it to them if they're going to feel more confident with it. Don't feel like we have to say, no brace, no brace, no brace. There's a reason they're telling you they feel more confident with it, so let's give it to them. 2 ACLs on the same leg. I play pro soccer. What are the best movements for prevention? Plyometrics, plyometrics, plyometrics. Hopefully that answered your question, Alex. Zach, what would you recommend? The reverse hyper for someone with bulging disc or a different exercise? I would first start with, well, if you have irritable bulging disc, meaning they're actually causing pain and discomfort right now, reverse hyper is probably going to hurt a lot. But as long as it doesn't, you're free to do whatever you want. Move however you want. If they're not irritable, do whatever you feel like doing. Let me know if you guys still hear me. I just heard my headphones kind of make some noise. So let me know if you guys are able to give me a thumbs up or something if you guys can hear me on Instagram. So make sure this is working. Can anyone hear me? I know it's a little delayed. Well, okay, perfect. I don't know how many of you guys have AirPods for Apple products. I used to think they were so weird. I was like, why do people want those in their ears? Like, I feel like they're just gonna fall out. Like, they're the weirdest thing ever. And my brother works at Apple too, so he had them for a while, since they first came out. I bought them, and I cannot live life without them. I don't know if any of you guys agree with that statement. I think they're the most amazing things ever. They're surprisingly staying super well. The quality is amazing. The microphone on it is epic. And not having cords, it's really cool. So and I asked my brother why they don't fall out. He was saying that so when we have traditional headphones and we have a cord, the reason why our headphones fall out like normal wired ones is for two reasons. One, the wire either gets stuck on something and we hit it, or the wire has all the weight. When it's just this, these things don't weigh much at all. It's actually the wire that weighs down the headphone, which causes it to fall out when you're jostling your head and stuff like that. But that was pretty cool. Apple does some pretty cool stuff. I'm gonna scroll back up here. Let's see, where are we? How to treat corn under the foot. Fato, let me know what corn meant. Maybe a little typo. Not really sure what the corn is. Maybe that's something I don't know. I don't know. Mard, quadriceps after ACL surgery. 100% agree. Quads. We're talking about ACL. Get your quads brutally strong, then your hamstrings, and then your glutes. Melissa, best rehab exercises for sternocleidomastoid and mastoid spasms. I would say this is very general advice, maybe some deep neck flexor strengthening exercises. We have a ton of that in our exercise library. Go check it out. I have a slightly torn labrum. Is my neck pain related to that? It could be. We don't know. It depends what type of tear you have. It depends how long it's been there. It depends how irritable it is. I would go see a physical therapist in person, have them assess you to see if there is that relationship. I guess it's more of a compensation than an actual referral pattern. But again, go check with the PT in person. Sean, what's your favorite activation drill before jumping? I do the neuropriming, so I took the Exos course. Neuropriming is any sort of quick feet, fast movement. It could be stuff in the ladder. It could be just in place. It could be going back and forth, side to side. Just like 6-7 seconds of just really, really quick feet. That's my favorite thing to do before I start to jump, and that's what I do with everyone before I jump. JMO, any suggestions for chondromalacia in the knee? I've had 4 surgeries, ACL included. That is tough, man. Best to consult with an orthopedic surgeon if there's something from a surgical perspective that you are worried about or that you're interested in. Know that you need to get your kneecap, or I assume it's your kneecap. You need to get your kneecap moving as much as you can. You need to work on your quad strength. You need to work on your butt strength. Get all the soft tissues around the knee as mobile as they can. But again, I'd consult with someone in person. Arash, who here is excited for the low back app? I know I am. So guys, we've been leaking this out slowly on Tuesdays. Our low back app is basically done. We just got the final rendition of it today. Our sales page is done. We're just waiting on testing to make sure everything works. It is epic. It is awesome. I'm so happy for this. I think it's going to help so many people around the world actually delivering care when people need it at the right time. I think that's the most important thing, especially for us in America. If you want to go see a doctor, you have to wait. And it's stupid. You have to wait not only for that doctor or PT to have availability, you also have to wait for the insurance to approve it. Some insurances need to have pre-approval before, so it's not even that you can go there. You have to get approval beforehand, and that approval then needs the physician to sign off on that. There's just so many boundaries and stupid things that prevent people from getting the care they need, and we hope that this low back app solves all that. So we're really, really, really excited for that. My cuboid bone in my foot keeps on subluxing. I've tried taping, it doesn't really work. How can it be treated? That's really tough. I would go see someone in person, see if you can see a PT in person to help you with that. What about Seguro? Can hyperextended knee be treated without surgery? Yes, Brianna. You have to figure out first, though, why is your knee hyperextending? Is there some sort of neurological thing? Is it just your quad is super weak? So when your quad is weak, which is the muscle in front on top of the knee, when you try to put weight on it on a bent knee, your natural ability is just to hyperextend your knee. That way you don't fall over. So it's actually smart that our brain does that, because if you didn't do that, you would just crumple to the ground. So more than likely, I've seen it a lot from an orthopedic standpoint, that's just quad weakness, but I would try getting your quad as strong as you can. BFR training from Jonah on early ACL rehab. Greetings. So first of all, for blood flow restriction, if you guys are at all interested and you're able to take a course with us, I would highly, highly recommend it. In our courses, we do cover a lot of the research, but we really, really focus on the practical application of PFR. The research is so strong. You can read the research all you want. It's about how we can actually implement it with our patients and use it differently, as long as you understand the principles behind it. So for me, for my ACLs, the ones that I get early on, I start with something called cell swelling, or either IPC, which is ischemic preconditioning, which is just putting that thing on, either sitting there or sitting there with quad sets and just seeing how someone gets acclimated to it. Know that with ACLs, they're arthroscopic. Hopefully all of them are arthroscopic now. I have seen some open ones from old ones. They're crazy. People that have gotten ACL surgeries like 20, 30 years ago, and the scar and how big it was. We've come a long way, which is amazing. But hopefully it's arthroscopic. They're almost all arthroscopic. Actually, I don't know why. I don't see any that are not. But know that the difference between like an ACL and a total knee is the time that they're under occlusion in that surgery is way less hopefully it's an hour or less of a surgery, not a couple hours for a total knee. There's not as much retraction as well. When they have the total knees, they have to retract that knee a ton. So there's a lot more damage to the vascular structures underneath. So I'm a little bit more cautious when I have those bigger surgeries, those open surgeries. For arthroscopic, I'm totally okay with getting them in right away, as long as other things from the surgery are being taken care of. Swelling's being managed correctly. That's probably the main thing. As long as swelling's being managed correctly, I'm down. YouTube questions from D Wins. I'm not sure what that means. Priyana, paralysis on my left side of my body. Please let me know exercises to strengthen my quads, please. So yeah, so it sounds like it was a neurologic condition. I would go see a PT in person. They're going to be able to help you out the most. Go see someone that specializes in neurologic conditions, because that sounds like you said what you have. So I would start there. So it looks like that is all the questions. Again, please give us some feedback on these. So we're doing a combination of Q&As that are like this, where it's just one of us kind of trying to answer as many questions as we can from you guys. And we're also trying to bring on as many people as we can. So I talked about an Oates procedure. We did a post on that last week. We're bringing on 2 orthopedic surgeons from Rush Orthopedics in Chicago to talk about biologics, things like PRP, stem cells. There's a lot of really, really cool research going on in that, and I really think that's where the future is going to be. Right now, again, it's not our expertise, but right now we are in the fix, the repair, the reconstruct, because that's what we know best, and our outcomes are really good. But what if we could, not even need to go down that route? What if we can just literally regrow and help repair these tissues on their own in people's bodies? I think it's really, really promising. I'm really looking forward to that talk and learn a lot from these guys. So hopefully you guys have been enjoying this. Please continue to give us feedback. Please DM us with your guys' feedback. Let us know in the comments here. And have a great Wednesday. All right, guys. See ya.